Good morning. We're going to get started with our scientific abstract session. I know everybody's coming in from getting lunch, but we do have a robust program here. We want everybody to have time enough to present, so we're going to get started. I am the chairperson of the Scholarly Activities Committee. I'm going to be running the session, and then Dr. Jane Hofnagel, Dr. Mario Gonzalez, and Dr. Helen Bean are going to be moderators. The session is going to showcase 9 abstracts that are going to be complex cases and scientific investigations this morning. These are going to be presented in person. There's going to be another session this afternoon, and it's going to start at 3:30. They're going to be all virtual presentations, but the presenters are going to be online for questions after those presentations. We're going to be scoring these abstracts, the moderators are, and the top 2 in each category are going to win monetary awards. You guys, as the audience, are going to have the opportunity at the end of each presentation to ask some questions. We're going to keep these presentations to about 7 minutes with the presentation and 3 minutes for questions. If the presentation goes too long, we may not have time for questions because we do have to keep it moving so everybody has an equal chance. At the end, the audience of each presentations, if you go on the mobile app and click on the session, all the names and the abstracts are going to be there. You as the audience are going to have 3 questions to answer or to score how the presenter did. And then your scores are going to be averaged and they're going to be added to our scores, and that's how we're going to get the top 2 in each category for the monetary award. So don't forget to vote. It's on the mobile app. Okay, so the very first one we're going to start with scientific investigations. The first presentation is a scientific investigation entitled Preoperative Antibiotic Administration, a descriptive analysis of outpatient surgeries at Doctors Hospital. It's going to be presented by Dr. Brian Large, who is a resident at Ohio Health Doctors Hospital. And I apologize ahead of time if I mispronounce your names. I'll do the best I can. So Dr. Large, come and do your presentation. The podium is here.
Good afternoon, everybody. Like she said, my name's Brian Large. I'm one of the CA3 residents up at Doctors Hospital in Columbus, Ohio. Our study was essentially kind of an internal study, just focusing on the efficacy of antibiotic administration at our own facility. The goal of this study was obviously to review what our current practices are, and with the intent to reduce surgical site infections. Essentially what we did was we looked at ANSEF administration, being that it's obviously the most common antibiotic administration that we give in the perioperative setting. We were looking to see if our site specifically adhered to the administration window that is set in anesthesia guidelines between that 15-minute to 60-minute window that we try to get those antibiotics in before surgical incision. Essentially what we did was we calculated the frequency with which these antibiotics were administered to see if they were given at the appropriate time. Our goal again was to identify the cases that received antibiotics within 15 minutes to 60 minutes of that surgical incision. It was a retrospective analysis that occurred between January 1st of 2021 and June 30th of 2021. Exclusion criteria for this study were those patients that were inpatient already receiving scheduled antibiotics, patients that did not receive antibiotics, probably on the, or given the fact that the surgical case did not indicate administration, and those cases where surgery time was not recorded. Of the 2,573 cases that we looked at, we had 448 that met our inclusion criteria. Our inclusion criteria were simply those patients that were age greater than 18 years, they met our date range, they were at our facility, and that they were undergoing outpatient surgery instead of being admitted or already admitted to the hospital. Shockingly, if you look at our results, we only had 15 of those 448 cases that actually met the specific criteria that we were supposed to be doing, whether that be that it was not documented correctly or it just was not done appropriately. which I don't think any of us would expect from our facilities, but if you take a deeper dive and look into that, it may shock you to find that your facilities are kind of in the same boat. I think the main reason that we went ahead and submitted this abstract for review at national conferences was just to raise awareness that even in your own facilities that may have what you think are solid practice standards, that you might be shocked to learn that your providers, your residents, those types of things are not adhering to the standards that you want. We have conducted our own internal reviews. We're hiring new pharmacists that are specific for the OR. We are meeting on a monthly basis to try and review this process and increase our efficiency with appropriate antibiotic administration to reduce any potential surgical site infections that we could prevent. Moving forward, we'll be studying further antibiotics, passing this on to residents that are below me in tenure, and trying to expand the study. So, thank you.
Okay, we're going to open up to audience questions, and some of the moderators will field them.
Yeah, I think kind of the changes that we've made are that we were finding that it was documented again outside that window. Either it was given in pre-op and the antibiotic was already done, started by the nurses, or we were finding that it was documented too far into the case where it wasn't given before that 15-minute window of it needed to be in 15 minutes before the surgical incision was done.
Do you think part of it was that they just forgot, like sometimes?
Right. Yeah, I think from personal experience, you induce the patient, you get everything hooked up, and then your antibiotic's sitting on your back stand, or it was maybe not handed to you from the nurse from the handoff standpoint, and you're scrambling to get that in before they actually get started. I think a lot of times I've at least witnessed this where you're going through your timeout and the surgeon says antibiotics and you're like, oh shoot, I forgot. So that's anecdotal from my own personal experience, but I would imagine that you can kind of extrapolate that out to every provider.
The other thing is, I don't know how many people have Epic, but we chart with Epic. When you go in, sometimes it's later that you decide to, you've given it, but you didn't chart it yet. If you don't go in and change the time,
right,
it's at that time that it records it, and it might have been
right.
Just recorded it.
And I think a lot of times too within Epic you see that it automatically has like a 5-minute window, so when you go to click there it might shift it forward 5 minutes later than you actually gave it, versus like reducing it down to a 1-minute time window and actually scrolling back and putting it in exactly when you did it. I've noticed that a lot of times when you click your induction and you click your intubation, it doesn't quite match up with like your SIVO timing. So I think that's something that we've tried to educate all our residents, our CRNAs, and our attendings on, and we're trying to be proactive to try and get those systems in place. Yep.
Other questions? I was just going to say, too, at our institution we have Epic, and of course we do say at the time out where antibiotics given. The other thing is sometimes our hospital has a protocol for different surgeries, and these are the standards, and a big committee at the hospital made that, and so if you automatically will give those antibiotics. If the surgeon wants it deviated, they specifically have to tell you or write an order for that, which I think is another safeguard, because you're going to give what is assigned so you know it ahead of time and you don't have to waste the time asking the surgeon, who may or may not be in the room when you start the case, if they want something different.
Yep, and we've had meetings with our clinical performance team and our pharmacists to come up with a better protocol, but also a better checklist system of making sure that things are done ahead of time instead of relying on us right at timeout. So. Other questions?
Have you noticed that once this was instituted that your surgical infection rate went down? I mean, I don't expect you to know that, but I don't know if you have any information on that at your hospital.
Yeah, no, I don't think we've looked deep into that yet, just given the fact that we're still, remedying the process, but we have had multiple meetings on the actual protocol and changes that we're going to make.
Okay, if There's no other questions. Let's give them a round of applause.
Thank you all.
The next presentation is also a scientific investigation entitled Concordance of Preoperative Right Heart Failure Risk Stratification and Pulmonary Vasoreactive Response Heterogeneity in Left Ventricular Assist Device Recipients After Surgery. A mouthful. This is presented by Dr. Jana Parikh, who is a medical student from Campbell University School of Osteopathic Medicine.
Hi, everybody. Thank you so much for being here today. I appreciate the introduction. I am not a physician yet. I am still a medical student. I'm in my second year at Campbell School of Osteopathic Medicine. And I'm very excited to be here today to present my project investigating right heart failure risk and pulmonary vasoreactivity in left ventricular assist device recipients. Here are my disclosures. Now, as many of you are aware, patients who have advanced heart failure will sometimes receive a left ventricular assist device, or LVAD, as a form of mechanical circulatory support in order to improve their cardiac functioning. However, one of the major complications that we see as a result of this procedure is the development of new right heart failure post-LVAD implantation. And this has become a significant area of research, especially as the prevalence of LVADs in our population continues to grow. One of the ways in which we can evaluate this outcome is using the Euromax right heart failure score, which uses key clinical variables to assign a numerical score that predicts the likelihood that a patient receiving an LVAD will develop right heart failure. Additionally, we know that patients who have a high pulmonary vascular resistance, or PVR, are at a higher risk of developing right heart failure due to the increased afterload that this places on the right ventricle. And for this reason, patients at many centers, including at Duke Hospital, where this study was conducted, will sometimes receive an inhaled pulmonary vasodilator, or IPVD therapy, as part of the standard of care in this type of surgery. So this leads us to the clinical question that we were hoping to answer with this project, which is, are the Euromax right heart failure scores associated with a favorable response to IPVD therapy as measured by a decrease in pulmonary vascular resistance? In order to answer this question, we conducted a secondary analysis of the InspireFlow clinical trial, which was conducted at Duke University Hospital with the primary goal of evaluating 2 different IPVD therapies for equivalency. Patients were considered eligible for the primary trial if they were older than 18 and undergoing one of 3 qualifying surgeries and did not meet any of these exclusion criteria. For this secondary analysis, we took a subset of patients from the LVAD cohort of the initial trial who met criteria for pre-existing pulmonary hypertension, defined as a pulmonary vascular resistance of greater than 3 Wood units. We also then calculated the Euromax right heart failure score for each of these patients. Possible scores range from 0 to 10.5, with higher scores indicating a greater likelihood of developing right heart failure. Finally, we classified each participant as either a responder or a non-responder to IPVD therapy based on whether or not they had a correction of their pulmonary hypertension. Of 38 patients who met criteria for the secondary analysis, 26 were considered non-responders and 12 were considered responders. These 2 groups did not differ significantly in any of the baseline characteristics, including age, race, gender, and other baseline clinical variables. And importantly, we did not find any significant differences between these groups in either the preoperative or the postoperative Euromax score, indicating that Euromax scores alone were not sufficient to determine whether or not a patient would have a correction of their pulmonary hypertension. We then wanted to evaluate the relationship between Euromax score and response to IPVD therapy on a more granular level by looking at the association between scores and the % change in pulmonary vascular resistance. So here on the y-axis, we have the preoperative Euromax scores, and on the x-axis, we have the % change in PVR, with the dashed line in the center. I'm not sure how well it's showing up, but the dashed line in the center indicating 0 or no change, values to the left indicating a decrease in PVR, and values to the right indicating an increase in PVR. And what we found here is that there was a significant positive correlation between the Euromax scores and the % change in PVR, such that lower scores were associated with greater decreases, and higher scores were associated with smaller decreases or even increases in pulmonary vascular resistance. And this was true for all patients. as well as when we stratified it further into the responder phenotype, with responders shown here in blue and non-responders shown here in red. However, there are several responders who had high Euromax scores but still had a correction of their pulmonary hypertension, leading us to believe that there are other factors that are influencing this relationship. So taken together, this all leads us to believe that the Euromax right heart failure scores are related to how a patient will respond to IPVD therapy, with lower scores associated with a better response, but that this relationship alone is not enough to determine whether or not a patient will have a correction of their pulmonary hypertension after this procedure and as a result of IPVD therapy. In the future, larger prospective studies are important to help further explore this relationship, and we are also currently investigating the clinical, metabolomic, and proteomic profiles of the patients from this cohort in order to determine if there are any factors that are related to their gene expression, protein expression, or other clinical profile metrics that could help further explain this relationship and be used as potential targets for therapy in the future. And with that, here are my references. And I, of course, would like to thank my mentors, both at Duke and Campbell, and as well as the InspireFlow team who were involved in data collection.
Thank you so much for that presentation. When I have to deal with a patient with an LVAD or an RVAD, I'm like, oh no. I think volume and phenylephrine and an A-line. So audience, any questions? Because I'm not really as much up on this as I should be. I was going to ask what other interventions that you suggest, but you said we need to obviously study this more, which happens that I see an abstract and I wonder how the presentation's going to answer my question, so you kind of did.
Yes, he's wonderful. Thank you so much.
All right, excellent job.
Thank you.
The third presentation is also a scientific investigation entitled Effects of Anesthetic Agents on Dementia and Postoperative Cognitive Decline, presented by Dr. Matthew Tam, a medical student from Nova Southeastern University, Fort Lauderdale campus.
Hello everyone, my name is Matthew Tam, and I'm a fourth-year medical student from Nova Southeastern University. So we have no disclosures. Thank you. So there are three proposed mechanisms about how inhaled anesthetics can lead to cognitive decline and dementia. Isoflurane, sevoflurane, and desflurane have been shown to impact the neurophysiology of the brain. This leads to increased expression of beta amyloid and tau proteins that are often found in Alzheimer's patients. The neuroinflammatory response to surgery and anesthesia resembles Alzheimer's disease, and tissue trauma during surgery also leads to an inflammatory response in the microglial cells. Anesthetic agents can involve calcium dysregulation, leading to anesthetic-induced neurotoxicity, which can induce cell death by apoptosis. Isoflurane has been shown to cause this effect the most. So we wanted to investigate postoperative cognitive decline. It's a known phenomenon explaining the short-term effects of anesthesia on memory. However, much remains unknown about the long-term effects, so we wanted to look into this, and we conducted a scoping review to explore the current literature. Using PRISMA guidelines, we investigated on databases including PubMed, Medline, and Cinehil. Our inclusion criteria included articles published between 2010 and 2023, full text in English articles discussing long-term cognitive decline with anesthesia, adults older than the age of 19, and clinically relevant data. So in our initial search, it came out to 101 articles, but then after we were going through our inclusion criteria, it only came out to 6. So that was a limitation of this. So our first study showed that surgery with halogenated anesthetics were associated with an increased risk of dementia compared to no exposure to anesthesia in the 20-year time frame. The second study found exposure to surgery and halogenated anesthetics were associated with a small but statistically significant decline in cognitive Z-scores measured at 4 and 8 year follow-up. The third study found that 100% of healthy participants who underwent inhaled halogenated anesthetics without surgery recovered to baseline cognition at 6 and 12 months. The fourth study showed exposure to appendectomy surgery and halogenated anesthetics did not increase the subsequent rate of Alzheimer's disease and related dementia. The fifth study that we found showed that 2 years after surgery with halogenated anesthetics, the number of Alzheimer's disease cases that emerged did not significantly differ from the control. However, the sevoflurane group showed a greater number of cases and mild cognitive impairment than the control group, measured 2 years after the surgery. And the sixth study showed that halogenated anesthetics and surgery are not independent factors for Alzheimer's disease development when followed up at a 5-year minimum. So the fourth, fifth, and sixth study showed no increase in Alzheimer's dementia. The first study showed a slight increase in dementia, and then the second and fifth study that I was going through showed an increased mild cognitive impairment. So results from this review are in support that halogenated anesthetics are not associated with Alzheimer's disease. The inhaled anesthetics may cause an increased risk for long-term mild cognitive impairment when combined with the surgery itself. Halogenated anesthetics without surgery were not shown to be associated with long-term cognitive deficits in healthy adults. And the topic of long-term cognitive decline of inhaled anesthetics is not well researched. We need more literature in this area. And from what we found also during this research was the surgery itself, from the inflammation and the cytokine release from the inflammatory cells could possibly be the result of causing calcium dysregulation, but not actually the inhaled anesthetics from the anesthesia. And these are our works cited.
Questions from the audience? And also remember to be putting on your mobile app how you felt these guys did for end results. I have a quick question. After seeing the results of your study, do you say anything to your patients before you give them anesthesia about the fact that there may be a slight increased risk in cognitive dysfunction from, and I'm not saying separate it with anesthesia or surgery, but the two combined? Do you mention that as anything when you're getting informed consent for anesthesia?
So I'm a fourth-year medical student, but during my rotations in anesthesia, some of the anesthesiologists would mention to the patients that there could be a postoperative delirium or postoperative cognitive delirium with some of the the younger patients. We've seen in younger, from what I've seen as a medical student, some of the younger adults waking up from anesthesia, from the inhaled anesthetics, are more combative or a little, they just have a different way of waking up compared to the, or as well as the elderly patients too.
Okay,
But,
I also, I mean, it's hard to tell in young patients how they're going to wake up, but in elderly patients, I do have a discussion with them, even if it's a regional, even if it's no sedation at all, because I don't think right now we can separate whether it's the surgery or the anesthesia, the halogenated agent, or together, the combination, that there could be a risk of this. And I've also had patients bring it up to me that, well, such and such, my relative had this, and then they were crazy afterwards. What's going on? And I think telling a patient, this can happen, it's very low risk, we don't really have any way to predict it or prevent it, but that we're going to give you the minimal amount of anesthesia that we can and get you through this. But I think some kind of reassurance is important because, it's something we all have to be concerned about.
One quick thing. You did not have ages of these patients, is that right?
ages of the
You weren't
patients?
able to tease out the ages of the patients in the studies.
I believe we were able to, I could go back into our, because I didn't include on the slides.
Okay, I'm just asking because sometimes the ages of a patient may also predict maybe not a rough wake up, but cognitive decline, because the older patients are, the chance they have more of of coexisting morbidities that may also contribute to what's going on.
This is a great topic. I love this topic. Just because most of you are medical students, when you enter residency, you'll realize for yourselves that it's really noisy. And imagine the noise and the distractions. I call it noise pollution that the patients inherit. You know, they're asked to come 2 hours early, they're waiting, they're talking, hearing nurses gossip, you know, talk about food in pre-op area. And for you to be cognizant of that just from this experience, I think will go a long way for you when you start residency.
Thank you.
All right, thank you so much. Give
Thank
a
you.
big hand. All right, the next several abstracts are going to be complex cases. So our fourth presentation is a complex case entitled General Anesthetic Considerations of a Patient with Cerebral Palsy, a Case Report, presented by Dr. Camille Hawkins, a resident from Ohio Health Doctors Hospital.
Good morning again. Thank you all for having me here today. All right, and as discussed, we'll be talking about, I know cerebral palsy is probably a pretty common disease that a lot of people see, but sometimes I don't think we think about all the other comorbidities they have that kind of make sometimes their care a little bit more difficult. I have no disclosures or conflicts of interest. For introduction, cerebral palsy is the most common motor disability in childhood. It happens about 2 in every 1,000 live births. And unfortunately, diagnostic rates have not changed in the last 50 years, so we've kind of stalled out on improving that. And it's usually diagnosed by age 2. Multiple common comorbidities include epilepsy, intellectual disabilities, emotional disabilities, chronic lung disease, chronic aspiration, hypotonia, malnutrition, a lot of pain, and sleep disturbances as well. So diagnosing cerebral palsy, multiple things go into it. However, multiple factors, maternal factors include problems with thyroid, pre-E, infection, prematurity. So if a baby is less than 28 weeks, they're a 10% likelihood of getting cerebral palsy. And term, if a neonate comes out with any encephalopathy, they already have a 12% chance of developing cerebral palsy as well. Assessing motor development is typically done. There's multiple different testing scores to do. Typically, it's found out at normal child checks. Neuroimaging was the most interesting. I thought 19% have changes in their periventricular white matter. However, 19% of brain imaging had nonspecific, and even 13% of people who are diagnosed with cerebral palsy will have no abnormal imaging. So really, it's kind of a crapshoot as to how much imaging can play a role into diagnosing. Prognosis is actually pretty well. 98 to 99% of patients with diplegia or hemiplegia will be able to walk. And being able to sit up at 2 years old is a good predictor of this. It as well as 2 years old is about predictions of severity are most accurate as well. However, about only 25% of patients with quadriplegia type of cerebral palsy will ever walk. And just to go over some definitions, Ogilvie syndrome is also acute colonic pseudoobstruction. It's not due to any mechanical obstruction, and it's very common in our patients who are bedbound. And for medical students, a cecal volvulus is the disease state where the cecal intestine rotates around the mesenteric axis. So today we're going to talk about this 34-year-old female, past medical history, cerebral palsy, spastic quadriplegia, seizures, peg tube dependent, scoliosis, nonverbal, malnutrition, chronic aspiration, and wheelchair bound. Past medical history is G-tube placement, ECMO, and a gastric fundoplication as well. She arrived to the ED via EMS for the mom's concern of 1 day of abdominal distension and for increasing agitation. At home, she attempted an enema, but there was no significant stool output. She is 4'11", she weighs 27 kilos. Her ideal body weight would be 45. Her heart rate's 147 and respiratory rate's 24. So she's in a little bit of distress, but she's stable. Pre-op review, her CT was suggestive of Ogilvie's. with a cecal diameter of about 14 centimeters with no evidence of mechanical obstruction or volvulus. Her pre-op labs, a little suggestive of malnutrition with potassium of 2.7, phos of 3. She had tolerated PEG tubes earlier that morning, so she did have a colonoscopy later that day, which was just done with a general anesthetic, natural airway with lidocaine and propofol pushes, which she tolerated great. At that time, they just found dilated lumen of transverse and ascending colon. The cecum did have a little bit of dusky appearance. However, the rectal tube was placed and the patient was taken back to the floor. However, overnight she clinically decompensated. She went into SVT multiple times and had to be converted with adenosine. She was hypotensive, hypoxic, and she was refusing to wear the non-rebreather. At that time, labs were rechecked in the ICU. Her potassium was 5.2 and her lactate had increased to 5 from 2. And so she was taken to the OR for an emergent XLAP. We were unable to assess her airway secondary to her cooperation, but she did have severe contractures and scoliosis as well. So our plan for her was we RSI'd with lidocaine, etomidate, and rocuronium due to her hemodynamics as well as her potassium. Unfortunately, this little one, she was a small human. Our GlideScope Low Pro 3 blade was too large to fit in her mouth, and at our facility we do not have smaller GlideScope blades. However, we were able to DL her with a Mac 3 with a grade 1 view. However, after induction, she was hypotensive, hypothermic, and she was non-responsive to fluid, and she did have high peak inspiratory pressures. Peak inspiratory pressure was about 38, and her tidal volume was only at 270. However, she underwent a midline laparotomy and identified ischemic cecal volvulus, where she underwent a right hemicolectomy and an ileostomy. It was about immediately that midline laparotomy was done, and the peak pressures went down to normalized. She became normotensive. Basically, she was likely having some form of compartment syndrome, starting of it at that time, but there was no need to diagnose it when we took her back. This is actually a picture of her case. You can kind of tell, I know it's hard to tell, but this from the surgeon's hand and the lap, and keep in mind that she only weighs 27 kilos. Like this is very large for how small the patient she was. We transported her back to the ICU, intubated and sedated and stable. 4 hours post-op, her lactic acid had decreased to 1.2. However, her MAG was 1.7, phos was 1.5, and potassium was 3.8. She was extubated on post-op day 1 because they did have difficulty weaning her from the vent because of low tidal volumes. However, that's was most likely her baseline. Her inpatient stay was complicated by starvation ketosis, but she was discharged home on post-op day 10, tolerating tube feeds. And as of last night, she hasn't been readmitted to the hospital, and this case was about in March. So the thing about this case, which made it difficult, was her comorbidities and identifying which issues would manage knowing her higher risks. Yes, she has seizures. We had to use etomidate, but she was also hemodynamically unstable. We had to RSI her, but she had we knew she probably could have a difficult airway. Most common complications of patient's cerebral palsy are hypotension, likely due to the injured hypothalamics at birth. And hypothermia is typically a little bit of the hypothalamic injury, but also they have an increased body surface area because of this malnutrition and being so small. Other more common complications are bronchospasm, laryngospasm, and they're also likely to have difficult IV access. They've been poked a lot their whole lives. So Aoca Gs is very common in patients with cerebral palsy. But however, the cecal volvulus is the uncommon part, which only happens about 1% of all bowel obstructions. When these pseudo-obstructions of Aoca Gs are managed both medically and surgically, they have increasingly high rates of complications and mortality. And then if the pseudo-obstruction, like this patient, evolves into a cecal volvulus, there's a 40% chance of mortality. Risk factors for death include advanced age, cecal diameter over 14 centimeters, prolonged period of 4 days, and requiring operative interventions. So this 35-year-old had 2 of the 4 risk factors, and they weren't in ascending order, they're just independent variables. So she had a very high chance of mortality. However, just in summary, we talked about hypothermia and hypotension as being the most common complications, more likely to have difficult airways and aspiration. And just a reminder that cerebral palsy is not a contraindication to succinylcholine, but just use your clinical judgment. And adults with cerebral palsy are more likely to have perioperative complications than pediatric patients. I know I talked about that there's still about 50 years we haven't made any good changes in decreasing the birth rates, but they are considerably living longer to 70 years old, so that might be something that more and more people are going to be seeing is now as these geriatric patients with cerebral palsy are at a high risk. Here are my references, and if anyone would like them, I would be happy to email them out afterwards. And thank you so much. What questions can I answer?
Real quick question, because I think we're almost out of time with this. What pain management strategies did you think for her afterwards with all this going on?
So for her, it was difficult because we didn't want to give, she was already on chronic narcotics for her chronic pain. So we did give her narcotics as she's chronically on them. However, for postoperative pain for her, to wean her from the vent was ketamine and Precedex would have been our main goals to get her off the vent early.
And then how did she manifest pain afterwards? I mean, what, just opioids treated her with?
Yeah, they just went straight back to her normal peg tube and kind of went off assessing her vitals to give it to her rather than the typical PRN asking for them.
Okay, thank you. Any other questions quickly? Okay, thanks very much.
Thank you so much.
Okay, our next presentation is also a complex case entitled Severe Pulmonary Hypertension and Elective Knee Replacement, presented by Dr. Aoca Gs, a medical student from Mount Sinai Medical Center.
Hello, my name is Vijay Karot. I'm a medical student from Midwestern University, but the case is from Mount Sinai. Just look that up. All right, so and I am presenting a case report on severe pulmonary hypertension and elective knee replacement. So pulmonary artery hypertension is a group of disorders characterized by mean pulmonary artery pressures of greater than 20. pH can have effects on perioperative outcomes, and we're presenting a case of a patient with pulmonary hypertension that underwent a total knee replacement for a septic joint complicated by cardiac arrest. So this is a 40-year-old male scheduled for a right total knee replacement complicated with a septic knee joint. His past medical history included mixed connective tissue disease, severe pulmonary arterial hypertension, WHO type 1, right ventricular dysfunction, pulmonary embolism, and a previous aborted procedure from cardiac arrest on induction of general anesthesia. So the anesthetic plan was discussed with the patient's pulmonologist and the orthopedic surgeon. Because of his previous history of cardiac arrest on induction of general anesthesia, we decided to do moderate sedation along with regional anesthesia, combining a spinal and an adductor canal block. So the patient received an adductor canal block on the right leg, and it was pre-medicated with 2 milligrams of midazolam and 25 micrograms of fentanyl. Upon entering the OR, oxygen saturation was 97% on room air, and he was responsive to voice. In the OR, we did the spinal at L3, L4, and after repositioning the patient, dexmedetomidine infusion was started at 0.6 micrograms per kilogram per hour, and then it was lowered to 0.5 kilograms per hour 22 minutes after induction and maintained for the rest of the case. 25 micrograms of fentanyl and 60 milligrams of propofol were given at the beginning of the case, and then additional boluses of 30 milligrams of propofol was given through the IV throughout the case. The procedure remained uneventful until tourniquet release. So after 124 minutes of tourniquet release, at 15:43 the cuff was deflated and immediate hemodynamic instability happened. The heart rate rapidly fell from 99 to 40, and the patient was unresponsive to 1 milligrams of atropine. 5 minutes later, the patient went into asystole, and ACL protocols were initiated. Compressions were started. The patient was intubated with 8 liters of oxygen. 1 milligram of epinephrine was given. 3 minutes later, another 1 milligram dose was given, and 500 micrograms of phenylephrine were given. And 5 minutes later, ROSC was achieved, and the patient's blood pressure got up to like 165 over 135, and he was a little tachycardic, so esmolol was given a couple minutes later. And then at 16:03, the surgery team arrived, and a right femoral arterial line and a right femoral central venous catheter were obtained. And after the patient was stabilized, prior to going to the ICU, the right IJ was placed for sterility purposes. And then while the A-lines and stuff were being placed, intraoperative TEE showed right ventricular dysfunction consistent with a previous TTE, so there's no evidence of any air or fat emboli. 2 minutes later, milrinone was initiated for reduction of pulmonary artery pressures along with ionotropic ventricular support, and the patient was started on 10 micrograms per minute of norepinephrine and 30 milligrams of furosemide IV and 10 milligrams of vecuronium boluses. CT surgery was there in case ECMO was needed. ECMO was not needed. The patient was stabilized, and once the patient was stabilized, pulmonary angiogram was done at the CT suite, and there was no evidence of any pulmonary embolism. So the patient was taken to the ICU, and the patient was successfully extubated with supplemental oxygen and nitric oxide via nasal cannula the following day. So with this patient, they went into cardiac arrest, and there was no evidence of any emboli or pulmonary embolism. We believe that because of how it presented right after tourniquet release, the cardiac arrest was precipitated by ischemia reperfusion syndrome and hypoxic vasoconstriction. So basically, the ischemia to the leg, the buildup of metabolites, CO2, lactic acid, once that was released, once the deflation occurred and it went back to the heart and to the lungs of the patient who already had high pulmonary artery pressures, the right heart couldn't withstand that, and the patient went into cardiac arrest. This type of patient creates an anesthetic management dilemma because, first of all, he had a previous history of cardiac arrest upon induction of general anesthesia. So then we decided to just do regional and do Precedex infusion throughout the case. We think that was still the correct process for this patient because we didn't want to do general anesthesia. In patients with such high cardiac risk, it may be necessary to consider the use of intraoperative TEE to monitor RV function in real-time cardiac changes. In our patient, we didn't want to do general anesthesia, so we only did the TEE once the patient was intubated, once the code started. And resources to prepare for worst-case scenarios. So the CT team was there in case ECMO was needed. They did arrive promptly to do that, so that was well done. Post-operative care of the patient, I think in patients with such high risk and with what happened, making sure an ICU bed is available, making sure that you tell the ICU team only extubate after all the anesthesia is worn off are very important. Also considering just post-operative analgesia, considering epidural versus spinal. We did spinal, but an epidural could also help with post-operative care. You can have the patient have patient-controlled post-op analgesia through an epidural and have longer-lasting pain relief. And so in conclusion, in patient with such high risk and patients with pulmonary hypertension, it may be reasonable to consider gradually releasing the tourniquet rather than suddenly doing it, and also strict adherence to tourniquet pressure guidelines. So I've read different studies and they kind of say different things, but for the most part, keeping the pressure in the lower or the lower extremities under 250. One study suggested that if you're going to have tourniquet inflation for longer than 2 hours, releasing the tourniquet every 30 minutes for a couple minutes could also help. I don't know how likely the surgery team will want to do that, but that is a consideration in patients in such high risk. And then also, like I said on the last slide, when completing orthopedic surgery on patients with pulmonary hypertension, just considering duration of tourniquet inflation, pressure, the anesthetic considerations that I suggested on the last slide, and then use of invasive monitoring and other team support. That is it. Any questions?
Remind me what level of training you're in?
I'm a fourth-year medical student.
Fourth year, okay. Sorry, I don't want to
Yeah,
make this an
grill me.
M&M.
I know you don't want to go into anesthesia, right?
So just two comments. Great job, all the medical students. I'm just totally blown away by your just professionalism and your engagement, and for being here. First one, this was for a septic joint. Was that right?
Yeah,
Okay.
it was, yeah.
Okay. So I'll keep it at MS4. So, all right, I'll leave it at that. And the second part is, as you enter your residency, you're going to go through, are we going to put this patient to sleep, or are we going to do a regional?
Yeah.
If you didn't know, going back, let's say you're seeing this patient for the very first time, history of severe pulmonary hypertension. Think about, I'm not going to ask you directly, I'm trying to be nice, but for you, how you would approach this patient. Do a regional, this is an elective TKR. Would you do a spinal, pre-induction A-line? Would you go a general all the time, every day, every single patient?
So in this specific patient, because of his history, because he had a previous history of on induction of general anesthesia of cardiac arrest, so I feel like that's why they strayed away from general anesthesia. I do think like doing the regional with the MAC was the right decision. Maybe not using propofol, maybe using like ketamine instead because of his previous history. I think that's maybe one thing that could have been changed. Although I do, it's hard to say just because he tolerated it seemed like he tolerated the propofol well for the duration of the case until literally the tourniquet deflated. So I don't know if the propofol is actually the reason or not.
I think one of the most important comments that you made was, the potential for intermittent release of the tourniquet depending on what surgical procedure you're in. Because you're going to see this not only in orthopedic procedures with tourniquets, but you'll see it with clamp time for vascular procedures and things like that, where you can't unclamp or allow these, mediators to circulate a little bit. But in a case like this, it might be worth a conversation with your surgeon to say, hey, look, I know this is not popular, but given the history, it might be more pertinent that we do this. And to her point, everything's risk benefit. So as you get farther and farther along, you've got to be willing to have those tough conversations and advocate with the patients.
Yeah, my question also, or just a comment maybe, we don't know why he had a cardiac arrest the first time. And I don't know what the general anesthetic was, but if you're anticipating a problem with tourniquet deflation, general anesthesia might be a better option. The other issue I have, you said prosthetics is great, but if you give a lot more, sedation, be aware of the increasing CO2 in the patient who has severe pulmonary hypertension. That may push you to a pretty high level of risk, and then the tourniquet goes down, and then all hell breaks loose. So just be aware. It's one of the other things to consider when you're thinking general versus regional, because we don't know why the cardiac arrest happened before. And I've put many people to sleep who have very high pulmonary artery pressures, and I'm scared to death of them, but I've done general anesthetics equally as well.
Okay, we are going to move on. Thank you so much. The next abstract is a complex case entitled Separated at Birth, presented by Dr. Matthew Levine, a resident from UMass Chan Medical School, Bay State.
Good afternoon. Thank you for having me. This is much better than being in rainy New England right now. I have no disclosures. So the case, the person is TD, a 49-year-old male with a past medical history of hypertension, vape use, renal agenesis, and an imperfect anus. He was transferred from a local hospital for shortness of breath and left-sided chest pain in addition to platypnea. An ABG demonstrated a pH of 7.53, PCO2 of 27, a PO2 of 41, a bicarb of 22, and an O2 sat of 82. So interestingly, prior to his presentation, he was able to cycle to work, someone that I aspire to be to some extent when I'm done with residency. Chest x-ray and CT were unremarkable. He was admitted to the MICU where he was weaned from a CPAP to high-flow nasal cannula and then to room air. Interestingly, they did a bubble study which demonstrated a patent foramen ovale or an atrial septal defect. A subsequent TEE confirmed multiple ASDs not amenable to percutaneous intervention with significant left to right shunt but a normal EF. Given the patient's history of imperforate anus, renal agenesis, and newly discovered ASD, Vactral syndrome was considered. So just in brief about Vactral syndrome, you have literally a mnemonic for it. 1 out of 10 to 4,000 babies are born with this syndrome. You need 3 of the findings to be present to be diagnosed. It is a variable presentation. Cardiac anomalies can be from an ASD to tetralogy of Fallot, and no single test can diagnose this syndrome. So obviously one big thing that we can kind of talk a little bit about later in terms of kind of overall picture is trachea. Just something to consider in terms of your other patients that have non-specified syndromes that have variable penetrance and presentations. So just a brief run with shunts. ASDs demonstrate a continuous left to right shunt. With left to right shunts, you can have increased pulmonary blood flow. Seems to be the theme of the day a little bit. So you can get some pulmonary congestion, increased work for the LV. You can have increased pulmonary vascular resistance. You do see a decrease in LV preload, decreased oxygen content in the ejected volume because you're losing some of it to the ASD. And actually in a normal healthy lungs, you have about 6 to 10% shunt from the Thebesian and bronchial veins. Obviously with the continued left to right shunt and the increase in the preload of the right ventricle, you can have Eisenmenger syndrome. So a reversal of the shunt direction due to RV remodeling and increased right-sided pressures. Nothing crazy from the anesthesia standpoint, as this guy was a young, otherwise healthy male. But this case highlights the importance of understanding a patient's history. I know that some people may have gone into anesthesia in order to avoid an HPI, but that's not something that you can always avoid. Alpha was also mentioned that this patient was adopted, so you're kind of having this black box of a history. So again, just goes to show that getting a history can be just as important in anesthesia, particularly when you only have maybe seconds, minutes, and really developing that understanding of a patient. Again, kind of going back to the tracheal anomalies, there was none explicitly in this patient. However, that doesn't mean that there aren't none. Obviously, we in anesthesia tend to get a lot more concerned about tracheal and bronchial anomalies, which are always possible. So it's just something to keep in the back of your mind if they're going to be a difficult intubation, obviously if they're a difficult intubation, difficult extubation, and really just planning for the unexpected. So these are resources. Any questions?
I had a couple things, but you went through some of them. So what if he needs an anesthetic?
Mm-hmm. Yeah, so I mean, if you're going into shunts, you're thinking about your onset of induction with inhalationals versus IV anesthetics. Obviously, IV anesthetics would take potentially a little longer if you're having that left to right shunt. Inhalationals, it's going to depend on how soluble your anesthetic is. So you're very, if any, use desflurane versus your isoflurane. They're going to have different onset of inductions because of your shunt. And it does depend if you have a left to right or right to left.
So these are all important things before you consider what type of anesthesia, probably a general, whatever you need, and how you tailor your anesthetic based on all the stuff that you told us this patient had, which is considerable.
Yeah.
Really a muddy picture there. Okay, thank you very much.
Okay.
Our next presentation is a complex case entitled Administration of Tiva with ketamine and propofol in an elderly male with Becker muscular dystrophy. This will be presented by Dr. Jacob Merrill, a medical student from LECOM Elmira.
Hello, everyone. So this case is on the administration of TIVA with ketamine and propofol, like was said. I have no disclosures or conflicts of interest. For the background, Becker muscular dystrophy is one of the muscular dystrophies, and this one specifically causes loss of dystrophin, and it can result in cardiomyopathy as well as respiratory compromise. Like other muscular dystrophies, it's associated with hyperkalemia and rhabdomyolysis when inhaled anesthetics or succinylcholine are used. Looking at the literature, much of it focuses on Duchenne muscular dystrophy, which is going to have a more severe disease course than Becker muscular dystrophy. So in Becker muscular dystrophy, we're going to have patients that might be older, they might have other comorbidities, or they might present at a later age in life needing surgery than with Duchenne muscular dystrophy. Our patient was a 65-year-old male. He had a history of Becker muscular dystrophy, hypertension, GERD, and OSA. He had presented with acute abdominal pain and had to be taken to the OR for an exploratory laparotomy. Prior to starting the case, the anesthesia machine was flushed with 100% oxygen for 20 minutes to remove any traces of volatile anesthetics. He was pre-medicated with 200 micrograms of fentanyl, and then RSI was performed using propofol, ketamine, and rocuronium, and a size 7 endotracheal tube. He was about 98 kilograms, so the math is easy for me. 120 milligrams of rocuronium, so about 1.2 mg per kg, and ketamine was about 0.5 mg per kg. After induction, he was a little bit hypotensive and required phenylephrine, but nothing too severe. And then he was ventilated throughout the case using fresh flow gas and oxygen, again, avoiding any use of inhaled anesthetics. And after induction, a bilateral 4-point tap lock was used for pain management using ropivacaine. During the case, he was maintained on propofol. He did require additional doses of phenylephrine for blood pressure, but not so much that a phenylephrine drip was required. No reversal agents were given for the neuromuscular blockade. And then this is a case that finished late in the night, early in the morning, so he's taken to the ICU upon completion, but he was able to be extubated that day. So for some of the discussion points, Becker muscular dystrophy doesn't increase the risk of true malignant hyperthermia, but we followed the same precautions in this case. So that was avoiding the inhaled anesthetics, avoiding succinylcholine, and just doing that because of the risk of hyperkalemia and cardiac arrest. For the induction agent, we chose ketamine for its advantages in blood pressure management, where it increases cardiac output and blood pressure, considering again that Becker muscular dystrophy, you can have some cardiomyopathy. And then the other thing we thought that was important was multimodal pain management by using the tap lock, and again using ketamine for induction, which has analgesic effects, so that we can decrease the use of opioids in the post-op period and any subsequent respiratory depression. So again, the learning points, BMD can cause cardiomyopathy and decrease the respiratory drive, and avoiding any inhaled anesthetics and succinylcholine. And then again, the importance of optimal pain control, especially in these patients where they have respiratory depression at baseline.
Questions from the audience?
Okay, I have a question. Maybe I'm showing my ignorance, but I guess you planned on keeping him intubated, because I don't know why we didn't reverse the muscle relaxant.
Trying to remember exactly why. It might have been, I don't know if it's just because it's such a long case, it ended up being over 6 hours. And because they took him to the ICU, if they just decided not to reverse.
I mean, that would make sense as long as you weren't planning on extubating, because there's, of course, a lot in the literature these days of reversal, reversal, reversal if you're going to extubate, because unless you're using a qualitative, is it qualitative? Quantitative method of assessing residual neuromuscular blockade because our patients, when we see 4 twitches, we think they're great, and that's not necessarily the case. They can get weak in the PACU, weak somewhere else, raise their CO2, and require reintubation. And a lot of times we're not looking at this. We see it in the PACU if we haven't reversed. So it was just a question. If you're keeping him intubated, I get it. Otherwise, make sure he's adequately sedated if he's still paralyzed.
This doesn't work. Oh, I had the same comment, was the reversal neuromuscular blockade. Actually, one of my partner, Dr. Wade Weigel, he was kind of the engine behind that article published in anesthesiology. And so it's standard care for our practice at my hospital and our department. And we keep every resident CRNA and physician anesthesiologist accountable. And we look at their quality metrics, you know. So if resident Brown is only meeting 50% threshold of documenting reversal, and how do you identify that? We use a stim pod or a twitch view and put greater than 90% reversal. So we do that for all of our patients who get even succinylcholine. That is a requirement for our standard work. But you won't see that at all of the practices. So just know that wherever you enter residency, your standards may be different.
Any other questions, comments? Audience, you guys are not participating here.
It's the alkaline tide after eating lunch, right?
Great presentation, all you guys. Thank you. Pulmonary hypertension, we see it. I primarily work at an ambulatory surgery center, and we see pulmonary hypertension every single day on many of our orthopedic cases. It's almost a given at this point. My question to you guys is this: in different references, different articles I've looked to, how do you diagnose pulmonary hypertension? Meaning, we try to lay very stringent, protocol to our referring surgeons. PA, maybe we have a 2D echo. Hopefully, we have one. There's dyspnea exertion, tremendous breath, baseline symptomology like that, and okay, we get an echo, and maybe it shows us a PA pressure of systolic pressure, or RV pressure of 30, 35, maybe 40, and we have a cutoff of 50 of RV systolic pressure. But I see in some references that they do mean pressures. So I was just curious, how do you guys determine your definition of pulmonary hypertension, and then what are some of the treatments you've seen for that? Thank you.
This was a question for us. I'm not sure that.
Not for you. No. Anyone in the audience want to take that? I'm not a cardiac anesthesiologist. I mean, I basically look at the studies that I've been given. If they have an echo and stuff and they show a mean pressure, then I figure out what's going to be moderate or severe with a mean, or if they're just giving a systolic PAS. I mean, I hate to see pulmonary hypertension, but we see so much of it, like you said, that if something is like 40, I'm like, well, that's not that big of a deal. I mean, I know when they have pulmonary hypertension, some of the risks that the patient is going to face. It's really nice to know what the RV function is, because you're going to be much worse if you have a bad functioning RV. And I've certainly had people with like PAS of like 95 over 60, and then it's like, is the surgery really necessary? Look at the pros and the cons, and make sure that the patient understands this, because a lot of times they don't. The one lady that I had whose pressures were like that, she was having back surgery, and it was for intractable back pain. And I said, I'm sorry you're having so much back pain. And she said, well, it's not that bad. And I said, has anybody gone over this with you? And no one really had. And then the surgeon came down on me and said, why did you scare my patient to death? And I said, well, this is something the patient needs to know. And we did the case, and everything went fine. We swanned her and stuff. This was a couple of years ago. But at the end, she crashed and burned, and she was intubated in the unit for 3 days. And I think that that's something patients need to know, too. So a workup is great, but I think that a bigger thing is making sure that your patients understand that there are potentials that you can't prevent this from happening, and what is the patient optimized and what is the surgical procedure. Could another one have been done that was not quite so invasive? Okay, so we're going to move on. Thank you so much. I do hate pulmonary hypertension. Anyway, our next presentation is also a complex case entitled Efficacy of Combined Subanesthetic Ketamine Infusion and Cervical Sympathetic Blockade as a Symptomatic Treatment for PTSD, TBI, in a Special Forces patient with a 1-year follow-up, a case report. This is going to be presented by Dr. Zubin Sethi, a medical student from Midwestern University, Chicago College of Osteopathic Medicine.
Hello everyone, my name is Zubin Sethi. I'm a 4th-year medical student at Midwestern University in Chicago, Illinois, and today I'll be presenting a case report demonstrating the efficacy of a combined regimen of ketamine infusion with cervical sympathetic blockade in the treatment of PTSD and TBI in a Special Forces veteran with a 1-year follow-up. So I'll begin by providing a brief overview of this unique patient population as well as this treatment regimen. So the Special Operations Forces comprise some of the most elite military personnel in our armed forces, consisting of Green Berets, Delta Forces, Navy SEALs, amongst others. And they are uniquely susceptible to this combined symptomatology of PTSD and TBI, specifically blast TBI, as they commonly engage in breaching procedures where they use explosives within close quarters. And they also dive from planes, which this induces this symptomatology. Unfortunately for this population, the current treatment guidelines, the first-line treatments are psychotherapy and pharmacotherapy. And the literature demonstrates limited efficacy of these treatments. In our search, we found that randomized controlled trials had dropout rates as high as 40%. So with this in mind, something had to change. And this is where we introduced the ketamine infusion. Numerous studies have elucidated the properties of ketamine infusions and their efficacy in treating PTSD, not only just treating it, but treating it rapidly and treating it in some cases immediately. And the mechanism of this action is proposed to be rooted in neurogenesis, as well as inhibition of the pro-apoptotic protein BAX. So this mechanism is proposed to have neurogenesis specifically in the hippocampus, promoting and enhancing memory function. However, the nerves that are most susceptible to this neurogenesis are sympathetic nerves. So this results in a downstream effect of elevated norepinephrine, which is associated with the symptomatology of PTSD. This is where we introduce the cervical sympathetic block, which directly induces sympathetic pruning to combat the sympathetic sprouting induced from the ketamine. More on the cervical sympathetic block. This was originally a 1-injection stellate ganglion block. Studies have shown that the utilization of 2 injection sites is more efficacious, and the proposed mechanism for this comes directly from our lead author. This diagram comes from his book titled The Invisible Machine, where you see that utilizing 2 different components of the cervical spinal column attacks 2 different parts of the brain. Specifically, we propose 2 different parts of the amygdala. So, for a more in-depth neurobiologic breakdown of what happens during TBI and PTSD and how ketamine and CSB together synergistically treat these symptoms, we have this diagram, and it's a very busy slide. There's a lot going on. So to summarize this, the cervical sympathetic block allows the ketamine infusion to have its maximal effect by ensuring that the adverse effects associated with elevated sympathetic activity are blocked. So with this in mind, we can now talk about our patient. Our patient was a 40-year-old male with an extensive combat deployment history over many years. His medical history is significant for multiple use disorders, multiple suicide attempts, multiple inpatient rehabilitation sessions, a long period of misdiagnosis, and he tried everything under the sun, from psychotherapy, pharmacotherapy, eye movement, desensitization, and nothing seemed to work for him. He constantly struggled with these symptoms you see here at the bottom for many, many years. So something had to change. And he was diagnosed with PTSD and comorbid TBI properly through MRI findings in 2019. at a military facility. So here we introduce what Dr. Eugene Lipov, our lead author, coined as the Special Forces method, which involves 5 subanesthetic ketamine infusions, beginning with an initial dose of 0.5 milligrams per kilogram, which is the standard dose, titrated up to induce a mild to moderate dissociation. As for the cervical sympathetic block, this involves a total of 12 cc's of 0.5% bupivacaine, with 8 cc's injected at the C6 site and 4 cc's at the C4 site. This is performed on 2 separate days, the right side and the left side, to prevent any adverse effects. Specifically, involvement of the phrenic nerve could result in respiratory depression. The way that we measured our patients' response to this treatment was through a series of surveys, specifically the PTSD checklist, Beck's anxiety and depression inventories, and the concise health risk tracking self-report, which directly measures suicidality. And for your reference, we see here what we use to measure these specific surveys. A drop by 10 is significant for PCL. There's different metrics for severity for these inventories, and suicidality, there isn't quite a metric for that yet. So we go on to our data, and it is nothing short of remarkable. Our patient was dealing with very invasive, very intrusive PTSD. We can see from these scores on day 0, and not only were his symptoms treated rather quickly and immediately, but they lasted for a year. And we recently got 2-year data, and I'm happy to say that every number you see here in this column for day 394 has either been sustained or been further reduced, which is quite incredible. So in conclusion, this combined regimen, Special Forces method, of cervical sympathetic block with subanesthetic ketamine infusion is highly efficacious in treating PTSD and TBI per our patient's report. And in his own words, this treatment has been the most impactful intervention in his day-to-day life. We must acknowledge that this is a limited case report, and there is a need for further study on this topic. With this in mind, our team has recently gained clinical approval for a clinical trial titled ROBRA, Reversal of Battle-Related Aging, where the primary objective will be to measure the effects on aging through the epigenetic clock Grim age, and the secondary objective will be to measure PTSD and TBI symptoms with a similar array of surveys. So here are some of my references, but for the full list, you can please scan this QR code. It'll take you to our publication in Helion. Thank you so much.
I have a question. Did the patient report to you on prior anesthetics that they woke up violent, or I think it is. Can you hear me? Did they report to you that on prior anesthetics they woke up violent?
No, I'm not aware of any prior instances of combativeness or violence.
I'm not sure. I understand the properties of ketamine and what they're doing for apoptosis and whatnot, but I would be a little concerned in using ketamine in someone with post-traumatic stress disorder and how they're going to wake up post-operatively.
So with these infusions, they're typically done over a 45-minute period where it's slowly infused. And the patient is placed in a very comfortable room. The setting is tailored to that patient, from the lighting, music, whatever that patient likes to be comfortable. So in order to combat any sort of combativeness, we have those metrics in place at the facility. And as far as I know with this patient, he tolerated the ketamine infusions very well.
I have a question. If he's maintaining beautifully, I think I know it's only one patient, but if he relapses, what is your plan?
Well, the plan at that point would be to repeat the process.
To repeat the whole thing?
And the reason I say that is because the initial procedure was to do a single right-sided cervical sympathetic block, and Dr. Lipov published that in 2008. He was the first to do that. And there was reported relapse of symptoms from the right side. And then he began doing right side and left side, and that was shown to be more effective and long-term.
Alrighty, this was great.
Thank you so much. Any other questions or comments from the audience?
Yes, and studies have been done for that as well with our facility.
PTSD was extremely common among all of us. And I was just curious if they're going to look at the possibility of working with post-traumatic stress disorder. Not all of us had traumatic brain.
Absolutely, absolutely. The goal would be to extrapolate this beyond just PTSD and TBI to PTSD in general. Not just PTSD amongst the military population, but PTSD widespread.
Now, is this clinic or your guys' facility, are you guys actually doing this for things like depression and other diagnoses?
Yes, so at Stella Center in suburban Chicago, these ketamine infusion and cervical sympathetic blocks are performed for treatment-resistant depression, anxiety, fibromyalgia, complex regional pain, amongst a myriad of other conditions. So the patients actually come directly through a military healthcare provider network. And at the facility, we have Dr. Lipov, who performs the procedures. He's a pain specialist. And we also have Dr. Nadro, who's an anesthesiologist, and he performs the sedation during the sympathetic blocks, and he monitors the ketamine infusions.
What do you use for sedation during the block?
Propofol. Propofol and Versed.
Do you guys utilize Versed at all to kind of ping pong off your question for abnormal reactions or anything like that, where the ketamine can kind of cause, psychomotor agitation? Or use any other drugs to kind of calm that patient?
Not with the ketamine, but for the cervical sympathetic block, we do give the patient the option if they want sedation. In that case, there's Versed, typically 2 milligrams, and then propofol infusion during the case.
Thank you so much. We have to move on. We have one more presentation. Our last presentation in this session is entitled The Management and Complications of a Dislodged Tracheostomy Tube and Potential Loss of a Patent Airway, presented by Dr. Samira Sheikh, a medical student from St. John's Episcopal Hospital.
Hello, good afternoon. Just a few clarifications. I'm a fourth-year medical student. The case was at St. John's Episcopal Hospital, but I'm a medical student at William Carey University College of Osteopathic Medicine. All right. Okay, so my presentation has some transitions, so hopefully it works. Background is going to be on tracheostomy, which everyone is well aware of. It's commonly used for patients recovering from respiratory distress. So it's life-threatening if it obstructs the airway, which is why airway management is so important. Especially in this patient, premature dislodgement allows the tissues to collapse on each other and reassertion can be difficult. So this is our case. So we have a 63-year-old male who has a chief complaint of respiratory distress and dyspnea, and he was brought to the ED from the nursing home. His past medical history is quite significant, but to shorten it, he has multiple complex comorbidities and a lot of psychiatric history as well, including schizophrenia and bipolar disorder and significant drug use, including cocaine, tobacco, and alcohol. So because of his history, his most significant history is pharyngeal esophageal cancer and the status post tracheostomy tube placement. So now his cancer involved a mass that was circumferentially obstructing his airway and leading to bilateral vocal cord paralysis, and he completed chemotherapy and radiation elsewhere. And now in the ED, on presentation, his O2 stats were in the low 70s. He was using accessory muscles to breathe, and he was tachycardic. So we did a chest x-ray, and overall we developed that he had multifocal pneumonia. And ultimately, we were considered, okay, so this is probably some kind of sepsis. So he was admitted for hypoxic respiratory failure and severe sepsis due to the multifocal pneumonia. So he was prescribed a course of antibiotics, methylprednisolone, neoaduanab inhaler, and Now, this is when things start to get a little bit more interesting. So the morning after admission, the nurses and everyone kind of reported, okay, so he has some sort of blood coming from the tracheostomy tube side. So we were thinking, okay, so let's try and pass a suction catheter through so that we can kind of get it out. But unfortunately, multiple attempts were made and they were not able to pass the tube through. So this was kind of interesting because the patient was not in respiratory distress. O2 stats remained in the high 90s, about 95%, and on auscultation, bilateral breath sounds were also heard. So we did a chest CT. So once we did the chest CT, we saw that the trach tube actually appeared to be outside of the trachea. So the imaging revealed a false anterior passage to the trachea. So the radiologist and the anesthesiologist were going back and forth about, okay, so what should we do now? So how is this patient being able to ventilate? So that was our concern at that point. So these are some questions to think about. So what do we do now? And should the tracheostomy tube be changed? Should we attempt the orotracheal intubation via laryngoscopy? And just a full little bit more information, this happened at night and there was no ENT surgeon on call. So it's just one anesthesiologist. This is at a community hospital. It's very small, and just there's no anesthesiology residents, so it's just that one surgeon or one anesthesiologist who had to make the call. So ultimately, what we decided was, because of this patient's extensive cancer and unknown extent of the obstruction and upper airway anatomy, we attempted that, this patient is doing well so far, so it's too risky to attempt any prior options. It could progress into an emergent surgical airway. Could we manage that? Maybe, but do we want to get there? Probably not. Again, there was no ENT surgeon on call, so our final decision was to go to the OR the next day and to do a tracheostomy tube revision because of his complex airway. I believe he got a size number 8. So he was eventually ventilating without difficulty. So we did a laryngoscope. And in here, we saw that there's this white eschar-like tissue and necrosis, which they honestly, the ENT surgeon had no idea what was going on. He suspected it could possibly be the tracheal air column. Like I said, the mass was kind of like circumferential and compressing the airway, so nobody really knew what was going on. And then the epiglottitis was visible, but it was a little bit edematous, and so we did a couple of biopsies, and afterwards, the patient was taken to the PACU in stable condition. And this is the chest X-ray, just to confirm the placement. So it was placed 2.5 centimeters above the level of the carina. So I think this case is just an overall presentation about, why and how did the trach tube get displaced, right? So there's a couple of reasons. One, it could be that positional changes. He came from the nursing home. We only know what goes on in nursing homes just from reported incidents. So maybe it's positional. We also hypothesized that it could be because of pretracheal fat that kind of was decreased due to his end-stage cancer. The patient also comes from a very underserved community, so we really don't have that much background information. And again, how was the patient able to ventilate despite having a displaced tube? So it's actually unclear. We're thinking that there was maybe some sort of slight connection, or maybe the radiologist could have gotten a different view, but given the fact that this was at the time of night and there was limited resources available, that was our best, idea of what could be happening. So I guess the learning points from this is, I think as physicians, and even, no matter what you're going into, I think you should have a high index of suspicion, especially regarding dislodged tubes, especially when patients present with respiratory distress and are on mechanical ventilation. I think it's important to consider all factors and to have a team-based approach. And I think education and training on difficult airway management is essential. Full disclosure, because I aim to be pretty transparent, I'm actually applying to physical med and rehab residency, so I still think all of this really applies because we have a lot of patients who are on tracheostomy tubes, especially SCI patients with cervical cord injuries, and I think knowing how to manage this is very important, especially from a rehab perspective. And this is my presentation. Any questions?
So a quick comment first, then we have a question. I am really glad that I work at a hospital that allows me to phone a friend.
What type of trach did he have?
I
Do you
think
know
it was just I know it was like a size 8 tube, so I know they were trying to replace it, but honestly it was all very like covered in like blood too, because it was like bleeding at that time.
8 is
So it couldn't be
pretty
clear.
large. So
Yeah.
I'm wondering if that's been
It could be.
replaced over the number of years. How many years did he have that trach?
It was only for
I had
like
a
3
case
months.
like this, so.
It was only for like 3 months. He had a very extensive cancer history, so he was just basically shifting from one hospital to another. But it was for about 3 months.
That's really scary if you don't have ENT
Yeah.
on call.
Right.
And I'm impressed that they waited till the next day to do this case.
Well, I think when I was speaking to the anesthesiologist, he was considering, I think like we should just hold off and doing like less is more, and that was a decision.
Yeah. Whenever a patient has radiation, multiple surgeries, flaps, etc., just know that their anatomy is abnormal to begin with, and that there will be false passages. But also remember the basics.
Right.
Look at the patient, evaluate, ask them questions. Hopefully they're not drugged up already, that they're answering appropriately.
Yeah.
But just see the patient is just what we go back to, and we should go back to when there's an airway issue.
Absolutely.
A quick question. I must have missed it. Did you guys put him in the unit or keep him PACU and someone watch him all night or something? Because
Right.
I
So
was scared.
after admission, he was taken to the PACU, and then he was taken back to ICU because of his very complex history. He eventually was stabilized after maybe like 2 to 3 days, and I think he was taken back into another hospital just for like telemetry and like monitoring for everything. He was not on mechanical ventilation.
All right, thanks everyone for your attendance. This is the end of this session. The second session is going to follow this afternoon at 3:30. It's going to be in the South Terrace, not in this room. We're going to have 6 additional complex case presentations and 3 scientific investigations. These are all going to be virtual, and they're all going to follow one case, the next, the next, the next, and when they're all finished, then the authors, presenters are going to be on virtual for questions after that. The same scoring we have on the mobile app, and you can do them after each presentation or wait till the questions, but that's how we're going to try to handle that so that we can get through them in a timely fashion, because I know that this afternoon or this evening is going to be the conclave and everything. And then once the scoring is all done, the top 2 in each category are going to get monetary awards. So I'm just absolutely blown away by the quality of everything, and I'm sure it will continue this afternoon. So thanks, audience, for your attention, and thanks, presenters. Again, I was like nowhere near this when I was at your stage of the game, so thank you so much.
Make sure that you vote.